I'm really delighted to welcome you to this inaugural lecture by Professor Paul Hutton. Paul, we are looking forward to hearing about the current challenges, understanding, and the practice in terms of your work in mental health care, exploring the true purpose of mental health care, and reviewing the different ways mental health illness is conceptualized. So I think it is going to be a challenge and very, very interesting for those of us who don't know your work very well. You know, we hear about your accolades, we hear about your research and your teaching and your excellence in terms of your standing in the sector. So looking forward to hearing about that. I'm going to give you a brief background about Paul. I cannot cover it all. So Paul is Professor of Mental Health in the School of Health and Social Care, and he is co-director of the Diana Manson collaboration. A little bit about Paul's education. Some of you might know more details, and I won't cover it all, so I'll just tell you where he studied. He studied his degrees in psychology at the University of Glasgow and clinical psychology at the University of Manchester. So he crossed the border and went south for that. He has extensive clinical experience within the NHS and most recently serving as principal research clinical psychologist at the Greater Manchester West NHS Trust Psychosis Research Unit. Before joining Edinburgh Napier in 2016, Paul was a Chancellor's Fellow in Clinical Psychology at the University of Edinburgh. Now, since joining us at Edinburgh Napier, Paul has held a number of leadership roles and academic roles, but I'll just focus on a couple. Paul was the school lead for postgraduate research, where he led several successful initiatives, and this was all to enhance the research student experience. And one I'd like to point to was the Clinical Academic Research Leader Training Program, which he implemented in 2017. Following that, he served as the school's Deputy Director for Research, and that was between 2018 and 2020. It's crucial, that period, because that was the lead up to the Research Excellence Framework, REF 2021, and he led on the Unit of Assessment 3 for the university. So we thank you for that, and we look forward to your contributions to the next REF as well. A little bit about Paul's research now. Paul's research focuses on understanding the causes of psychotic symptoms, impaired decision-making capacity in the context of psychosis, and developing effective interventions to reduce psychotic symptoms and improve decision-making capacity. He has collaborated on numerous clinical trials of psychological interventions for psychosis and has published extensively on various aspects of psychosis. I'm sure Paul is going to point us towards some of the relevant pieces of work and will highlight the impact of that. Notably, though, I would like to highlight that Paul was part of a team that completed the first trial of cognitive therapy for people with psychosis who are not taking antipsychotic medication, and has led groundbreaking research on improving treatment decision-making capacity in psychosis. Paul has got national and international standing. He was a member of the expert committee that developed the 2018 NICE guidelines on supporting decision-making for people who may lack mental capacity. Paul is integral to the research the university does in this area, and he was an invited member of the Scottish Mental Health Law Review Capacity and Support for Decision-Making Advisory Group. Quite a mouthful, Paul. And continues to collaborate with Professors Colin McKay and Jill David on related matters. So I've just given you a snippet of Paul's research and the impact he makes and the continued contribution he makes both to policy and advice in terms of the NHS. So without further ado from me, I'd like you to help me in welcoming Paul. Sorry, I've bit my tongue earlier today. And so speech is a bit challenging at the moment. So let's welcome Paul then to give his inaugural lecture.
Thanks very much. Okay. So can everybody hear me at the back? Hi. Great. So thank you very much for that introduction. That was exceedingly uncomfortable listening to all that. But thank you very much for discussing stuff I do. Today, I'm going to talk about a new way of conceptualizing mental illness. I'm going to talk about what we've called sort of need for care approach, which involves the concepts of autonomy and suffering. So there's quite a lot to get through, and some of the stuff is a little bit tricky to explain. So please bear with me. If you have any questions at the end or haven't explained anything, please do let me know. So my three related aims are to provide a kind of critical overview of current approaches to mental health care, consider what its purpose ought to be, with a particular focus on my area, which is severe mental illness, in particular schizophrenia, and relatedly acute inpatient care, and to review and appraise the various conceptualizations of mental illness or disorder, which influence our current approaches, and then to introduce this new way of thinking about things and go through the implications, theoretical and clinical, of that. I've just started my timer because I'd forgotten to do that, so I don't know if I can get away with that. So to begin with, I don't want this to be an esoteric academic discussion. I think it's really important we bring this back to what matters, which are the people that we try and help. So this is a case, Natalie, not her real name. And it's not my case, but I've worked with a lot of people, very similar situations. So Natalie was accompanied by angels. They used to sing to her and she to them. Natalie would often dance with her angels, but this caused no particular problems. Natalie refused to take medication because she believed that it killed her angels. So just to introduce you to Natalie, just hold Natalie in mind as I discuss some of the concepts and the ways of thinking about it. Think about how these different conceptualizations might impact on how we respond to Natalie as a mental health service and as a society. So what are the aspirations around mental health care and treatment currently in the UK? Well, foundationally, our ethical aspirations are that respecting autonomy is incredibly important, but also that it's more than just leaving people alone. It's more than just non-interference. We also have an obligation to support people to regain autonomy when that autonomy is impaired, which is something that comes up an awful lot in mental health. And that's a quote from Beecham and Childress, Principles of Biomedical Ethics, which is an incredibly influential textbook of ethics. Picking up on that theme, though, and that was 2001, fast forward 20 years, the World Health Organization, everybody must have the right to make decisions themselves about their health and medical treatment. And the General Medical Council, in their guidance for doctors, all patients have the right to be involved in decisions about their treatment and care and be supported to make informed decisions if they're able to. This is the Schizophrenia Commission, which was 13 years ago. I don't think a lot has changed since then, if I'm absolutely honest, which is very sad. If anything, it's probably got a bit worse. But acute services need to be places of safety and rehabilitation that people choose to be in when they're ill, rather than choose to avoid. We recommend that a test is introduced called a friends and family test for acute mental health units, whereby if you need to think about whether this service is a service that you would want to be happy with your family and friends going to. And this is a statement from the NHS long-term plan 6 years ago. Therapeutic environments provide the best opportunity for recovery. Recovery-focused care is the goal from the outset. So these are our aspirations. And the recent Wesley review well, not recent, I keep saying recent things have happened 7 years ago, but the Wesley review of the Independent Mental Health Act in England and Wales made this statement, that improving patients' and service users' ability to make decisions about their care and treatment is essential to upholding dignity. Okay, so let's think about the problems. This is a qualitative study we did a few years ago in Manchester in the inpatient environment, and a quote from a person who'd experienced inpatient care. They were just making decisions. There was no warmness, no warmness. I felt like an effigy in the corner. I prefer independence, taking some sort of action within myself, and all of that was ignored. The independent review of the Mental Health Act said too many people are detained in wards that are far below the standard anyone would want for themselves and their loved ones. The physical environment and the sound levels make hospitals seem little different to prison. And a study that my colleague up there, Aaron, was involved in, reviewed the mental health report submitted in Scotland in relation to people, in relation to applications for compulsory treatment, where part of that involved demonstrating the individual has significantly impaired decision-making ability. In only 4 out of 100 cases they looked at, they found any evidence that the psychiatrists or the clinical team involved had engaged in any attempt to support people to make their own decisions. And that replicated an earlier finding in 2018. So this is the structure of the talk I want to give today. I want to talk about what our goals of mental health care should be. And I'm going to then followed by that, I'm going to talk about the underpinning principles about the approach that I'm going to articulate. I'm going to review the conceptualizations and relatedly a conceptualization of autonomy, and then discuss the implications. So what are the goals of mental health care? First of all, why is it important to ask that question? This is Harry Frankfurt. He's a professor of philosophy at Princeton University. He passed away a couple of years ago, and he had a major influence on moral philosophy. But his point here, fundamentally, is that we cannot reason ourselves into caring about things, but caring about things and valuing things tells us how to reason. So it's absolutely important. So that tells us that our values, what we care about, are at the heart of our practical decision-making and reasoning. So it's really important we understand what they are. So this is what I believe. Our goals of mental health care influence pretty much everything. Our concepts, who we offer help to, service design, treatment development, classification. It influences what we think we need to know and what we think we know. So put simply, why is it important to ask this question? Well, because our goals drive everything we do, or at least they ought to. So what are these goals then? Does anybody have any suggestion of what the goals of mental health care ought to be? Don't worry, I've got something up my sleeve.
It'll be people's well-being.
Sorry?
People's well-being.
Brilliant, I've got that one. Curing the sick. Okay. I've got that one as well. Fantastic. Thank you. Good. She's seen this before. Possibly. Rehabilitation to society. Interesting. Okay. Yeah. So this is just what I sketched up based on my knowledge and reading things, and there's a lot of different goals out there. Suffering, reducing disability, functioning, restoring functioning, reducing harm to self, quality of life. Somebody mentioned that. Did you mention that? Reversing dysfunction. I'm not saying I endorse all these goals. I'm saying these are goals that people have or talk about when they talk about why we provide mental health services. Autonomy. There's one in there, normality, restoring normality. Nobody mentioned that here, but we have textbooks of the journal, the abnormal psychology. Abnormality features, restoring people to normality features quite heavily in a lot of current accounts, particularly in America. So, but importantly, in terms of making sense of all this, we can start to think about how we classify these goals. We can start to think about how we classify them in terms of the type of value they hold for us. And there are two general categories of value. One is instrumental value and one is intrinsic value. Things that are intrinsically valued don't really need further justification. So imagine you're having a conversation with a child and they're doing that thing where they go, well, why? But why? But why? Something that has intrinsic value is when you stop. Say, but why do you care? Why do you care about my sister? Why do you care about that? Just because I do, because I love her. But why? Just because I do. As an intrinsic value. Instrumental value is something that gains value because it helps us to achieve those intrinsically valuable goals. And it's not unusual to get them confused. But we need final ends. We need things that have intrinsic value because they're the most important ones. So we can classify our various goals and we can think about how we classify them, whether they're intrinsically valuable, the degree to which they're instrumentally valuable, the degree to which they're intrinsically valuable. And I argue we can also classify them along another continuum, the degree to which they involve autonomy and the degree to which they involve suffering. So we can put those axes together and we can start to think about where these different goals lie. And my argument, and I'm happy to argue this with somebody, is that things like normality, functioning, disability, symptoms, dysfunction, disorder, have instrumental value at best. They're not intrinsically valuable. Restoring somebody to normal functioning is that actually important in and of itself, or is it important? Well, that's a very good question. That raises that question as well. You can answer that question: what is normal functioning? Through statistics, looking at the average, etc. But you can't infer a statement about how you want the world to be from an observation of how it is. What I would say is that if I was to say to you, I think the goal of mental health services is to reduce suffering and distress, it'd be quite a strange response to say, but why does that matter? And that therefore it has intrinsic value. So the one thing I couldn't fit into that graph is this one, and arguably it's one of the biggest drivers of our current inpatient system and mental health system, is reducing harm to others. And that's because I haven't been able to work out how to include that. I'm not saying it's not important, I just am struggling to include it. So what are the goals of mental health care? Well, I propose to you they're to reduce suffering, restore autonomy, and possibly reduce risk of harm to others. So what are the underpinning principles behind the approach I'm going to sketch out today? Well, very quickly, evidence-based practice and values-based practice are absolutely fundamental to thinking about this approach. And to the clinicians in the room, this won't be an unusual definition. It's the idea that we use the best available evidence in making decisions about the care of individual patients and their values. So I won't dwell on that. People are less familiar with values-based practice. This is Professor Bill Fulford, who's a professor of philosophy, formerly a consultant psychiatrist, and he's been involved in a lot of work around the philosophy of psychiatry and so on. And he's one of the developers of the concept of values-based practice. And one of the weaknesses of values-based practice is it's a little bit complicated. Evidence-based practice has its 3 pillars. Values-based practice has about, 10 or something. So it's a little bit complicated. You can read all that. Can people read that? So. Well, to be honest, the things that matter for our purposes are the insight it gives us that all decisions involve facts and values in healthcare and generally. But also, we only tend to notice the operation of those values when there's disagreement. When we disagree about whether a particular experience is a symptom or a gift, for example, there's often disagreement. And it's in mental health care that we see the most disagreement. We don't see a lot of disagreement in cardiovascular services or in cancer services. In mental health services, we see a lot. But the fact that there isn't disagreement in these services doesn't mean that values aren't in operation. They are, it's just that we all agree with them. In mental health care, they're as present, but they're often controversial. And that's why there's so many fights and arguments. So, but it's important to be aware of that. And now I'm going to move on to thinking about our conceptualizations of mental illness. So, why does that matter? Well, we know that the conceptualization that clinicians and various people hold, and people on Twitter and so on, who are arguing with each other, the conceptualizations they hold of mental illness are incredibly important in sometimes causing people to talk past each other, insofar as people have these particular assumptions about what mental illness is. And somebody else from a different background has a different assumption about what it is, so they have different goals. And that can create conflict. And I suppose my argument is what should happen is that the goals, understanding what the goals of mental health care are, should drive our conceptualizations and our recommendations about treatment. But what probably actually happens in community mental health teams and in acute inpatient wards is that the concepts of mental illness that the practitioners come to work with guide their goals or determine and influence their goals. So sometimes, so essentially, I would argue there's a degree of tail wagging the dog here. So why does it matter? Because how we conceptualize mental illness has an implicit, we're not really aware of it sometimes, reciprocal and I think sometimes undue influence on what we believe the goals of mental health care ought to be. So let's turn to those approaches, the approaches that cause people to disagree, and the approaches that cause the controversy. The diagnostic approach is the dominant approach in mental health. It's a prevailing framework. It involves the classification of clusters of symptoms and signs. The current diagnostic framework is meant to be neutral, theoretically neutral. It's meant to be descriptive, and that's meant to be one of its strengths. It's embedded in our systems, and it strongly informs treatment decisions, but less so probably risk assessment. And one particular impact of the diagnostic approach is around this concept of insight, which can cause some challenges. This is a definition of mental disorder from the World Health Organization ICD-11, and this is very, very close to the American DSM-5, which has been hugely influential. There are some additional caveats in the DSM, which is around the role of the degree to which your beliefs and experiences are socially and culturally acceptable and so on. But ultimately, what I've done there, what I've highlighted are the value statements. The clinically significant disturbance, dysfunction, usually associated with distress and impairment. So this is what they believe the goals of mental health care should be, to reduce disturbance, to resolve the dysfunction, to reduce distress, to resolve the impairment. There's a lot of work being done by the first value there, the clinically significant. There's a lot of work being done. Some would say they're not really answering the question. If mental disorder is what clinicians treat, what does that tell us? Clinicians are going to the manual saying, what's mental disorder? And the manual says, well, it's what you treat. We end up in a bit of a tailspin. More importantly, that one of the diagnostic approach can be compromised or does meet this particular challenge. And this is Ian Hacking, who passed away again a couple of years ago, professor of the philosophy of science, who observed that mental health disorders and the classification of mental health disorders are unique by the fact that people become aware of the classification and they start to change. They start to think about what it means to have a diagnosis of autism, ADHD, bipolar disorder. His work was done in the context of multiple personality disorder. So he talks about how the classification can change the people who are being classified, and they start to change their behavior and they start to seek help. They start to form support groups, start to form charitable organizations. So we have this feedback effect. So weighing up the strengths and weaknesses of the diagnostic approach, on the one hand, I firmly believe, I'm not dismissing the diagnostic approach at all, I'm taking a critical appraisal, applying a critical appraisal to it, but I think I think it's indispensable, primarily because it can identify and make predictions about, for example, highly treatable medical or neurological causes of experiences. I think it is a strength that it's neutral about causation. And I think it does aid communication. But the values in the diagnostic approach are embedded, they're hidden, they're inconsistent across different categories, and they're controversial, but they're not always presented as if they're values. They're presented as facts. Now, that's the diagnostic approach according to my view. The social model is in the ascendancy at the moment, and I've been having lots of discussions with my good colleagues, Professor Mackay and Stavert, sitting there around the implications of this. And the social model stands in opposition to this medical model, and by proxy, the diagnostic approach. It's strongly influenced a very important statement from the United Nations Committee on the Rights of Persons with Disabilities, which in turn has strongly influenced recent guidance by the World Health Organization and the United Nations around mental health, human rights, and legislation. These are the two documents in question, if anybody's interested. They're having a huge effect. They're causing governments to review their legislation to see whether or not it's in adherence with the interpretation offered. It's having a huge effect throughout the world. It's causing a lot of consternation. And it's strongly influenced by the social model. It's a rejection of what they refer to as the medical model. So what is a social model? Well, this is Peter Beresford, who's a service user and a researcher, and was as Emeritus Professor of Citizen Participation. And it's this idea that, and this is his interpretation of the social model, and he's one of the people who've tried to apply it to mental disorders. And it's this idea that much of the problems that people encounter are actually related to society's response to those problems. And if we make adjustments to how we do things, we can actually remove a lot of those impairments and we can operate on a level playing field. I'm looking nervously at Jill and Colin to check whether that's a reasonable take. This is Tom Shakespeare, who's also a Professor of Disability Research at London School of Hygiene and Tropical Medicine. Is very well known and famous in relation to this area. He's a bit more scathing and a bit more, I would say, succinct about the definition of the social model. And he says, it argues that the disadvantage experienced by disabled people owes nothing to their individual impairment. It's entirely the result of the social organization which serves to exclude disabled people. So, in my view, that involves quite a significant commitment to a particular level of explanation of people's problems. When biological psychiatry has tried to do that in the past, they've rightly been criticized as reductionist. And reductionism involves taking a complex phenomenon and trying to reduce it to one level of explanation. I think it's very important because it aims to tackle disadvantage and it aims to empower people and emancipate people. And it encourages to focuses on our restrictive policies and practice. There is an argument, though, when we start to apply this to mental disorder, that there's a kind of, that we have to bear in mind that emancipation or freedom from psychiatry is not a goal shared by all people who use mental health services. In fact, very many people who use mental health services are very happy with the care and treatment they receive, but they don't tend to campaign about that. I also think it can be disempowering, telling somebody that their problems or the difficulties they face in their life are a function of social forces that they cannot control. It might help you feel better and not feel blamed or responsible, but it also doesn't give you much to change. The third approach I want to talk about is the complaints-oriented approach. And this approach has led to breakthroughs, I would say, in the treatments in treatments for psychosis, which is my area. It's contributed to some skepticism about key diagnostic entities, and some people have suggested that it is actually quite close. It reflects the sort of reality of actual psychiatric prescribing behaviour by psychiatrists. In that, well, we'll talk about the approach to defend that point. I'm looking nervously at my legal colleagues on one hand, and nervously at my psychiatric colleagues on the other. Hopefully, they can just argue with each other later. So this is Richard Bentel. He's Professor of Clinical Psychology. And he revived or pushed forward this complaints-oriented approach. And his argument is fundamentally that we should just abandon psychiatric diagnosis full stop. And instead just try and explain and understand the actual experiences and behaviours of psychotic people. So this could apply to all mental illnesses. It doesn't have to just be psychosis. So he says, why don't we just look at these individual experiences that people have and try and understand them and try and help them? And what really matters is that they cause distress. And that's pretty much it. And if we reduce the distress associated with each of these individual experiences that people have, or the symptoms they come to us, there is no mysterious disorder left to treat. That's had quite a significant impact on psychologists in particular. The values involved in that approach are explicit, simple, and uncontroversial. What's lacking this approach is there is no consideration. It's entirely focused on distress and suffering. There is no consideration of autonomy. And I presented this to Sheffield recently, where Richard is currently based. And he's pretty open to that autonomy is an important omission in this complaints-based approach, and that actually we need to really think about this. So this is now coming to the approach which I advocate for, called the need for care approach. And essentially, this approach invites clinicians to evaluate each experience that a person presents with in terms of the suffering, i.e. the distress and impaired autonomy those experiences involve, regardless of whether that's normal or unusual, or whether it's caused by something inside them or something external to them. It respects a plurality of values in operation in the mental health sphere. But if there is any barrier to treatment, it's around the use of our resources. And so principles of distributive justice should govern the allocation of resources. For example, allocating them to people most in need. That is the criterion for offering help, not whether or not somebody has a mental disorder. So it focuses on understanding and treating problems associated with individual experiences, but we've adapted the complaints-oriented approach to include autonomy rather than distress alone. Basically, we regard an experience as clinically significant if it causes a patient stress, impairs their autonomy, or places the patient at significant risk of either outcome. I'm not talking everyday distress. Obviously, I'm talking about severe distress, severe impairment in autonomy. And that simply reflects the normative judgments that suffering and loss of autonomy are intrinsically undesirable. We care about that. We want to help people who present, who are suffering and who've lost their autonomy. Some of the criticisms of the approach are strengths, might be strengths when viewed by another approach. In contrast to the social model, it doesn't involve any commitment about causation. It's quite happy to consider internal and external factors. It needs to be developed further. So when we what we talk about quite a lot in this approach is this idea of autonomy. So what is autonomy? And I'm not going to, I'm aware there's thousands of years of philosophical research, starting with Socrates, Aristotle, and I'm not going to try and synthesize that. You'd be relieved to know at this point in the talk. But what I am going to do is offer a pragmatic account. What we mean by treatment-related autonomy in this model is something that has intrinsic value, sometimes has instrumental value, everyone cares about it. Everybody, clinicians, patients, family, everybody cares about it, but almost everybody disagrees about what threatens it. And that's one of the key sources of a lot of the debate. To have autonomy, to pursue autonomy is a right, not a duty. We shouldn't force people to have autonomy if they don't want to. We consider it synonymous with self-governance. The need for care approach acknowledges that. So those who favour a diagnostic approach may be more likely to focus on the threats posed by symptoms and cognitive impairment to autonomy, whereas advocates of a social model might consider the primary threat to be the mental health care system itself and its use of compulsory treatment. We think both of those things are true and not mutually exclusive, are probably true for some people some of the time. But the relative contribution of these internal and external threats will vary across individuals and their circumstances. So what are the implications of this? Well, there is a key theoretical implication which I'd like to flesh out just now. And it relates to this question: what is mental disorder? Lots of books have been written about this. By Derek Bolton, Lucy Fox recently, Richard McNally. What is mental illness? This is what mental illness is. And this is what it isn't. There's a lot of ink spilled trying to grapple with this question. You'd think it would be easier to resolve this question than it apparently is. Say recently, in 2005, Rachel Cooper, who is a professor of philosophy who's studied classification in psychiatry, she made a proposal that mental disorder is somebody has a disorder. She uses the word disease, but she also means disorder. That it's a bad thing to have, that the person is unlucky to have it, and that it can be treated. That's her definition. Potentially be treated. Now, the claim that the sufferer must be unlucky, she uses that claim to distinguish diseases from conditions that are unpleasant but normal. And she uses the example of teething, which is sort of universal in children. And every parent here will know it's actually pretty horrendous when a child is teething. But it's unpleasant but normal. That makes sense, doesn't it? We don't want to call teething a disease. Maybe we do need to exclude normal forms of suffering from this definition of disorder. This is I haven't got the sources for this. Teething symptoms, believe it or not, somebody's done a systematic review, meta-analysis of studies of teething, and they have found that 80% of 0 to 3-year-olds will report or experience teething symptoms as reported by parents. But there's a disease called respiratory syncytial virus infection, or RSV. It's very common. I don't know how to pronounce it. The doctors are laughing as I'm trying to spit that one out. But by the age of 2, it's estimated that every single child will have experienced RSV. So it can't be a disease then, if the person has to be unlucky, because then, so why? That can't be right then. My point here is that her definition requiring people it to be unusual or abnormal for that person cannot form any part of the definition of mental disorder. Even when we think about dementia, when you're 75 years old, you're more likely to develop dementia than not. I'm sorry to tell you that. But the prevalence of dementia from age 75 to 95 is 52%. Cancer, almost everyone will get it. Or, sorry, 1 in 2 of us will have it during our lifetime. But nonetheless, she is speaking in that definition to a very important concern, and it's this threshold between normality and abnormality. And when the DSM was being revised, a lot of people made a lot of money out of writing books about how terrible it was that the DSM, the American Psychiatric Manual of Mental Disorders, how terrible it was that they were seeking to expand the definition of illness to things like social anxiety, shyness, bereavement. And a variety of people. The one in the top right-hand corner, Alan Francis, he was chair of the DSM task force who developed the previous version of the DSM. He was pretty cross about what he saw as a kind of mission creep. So there's a real concern, both in terms of the critics of psychiatry, that there's a real concern from the critics of psychiatry that normality is being pathologized. So to some extent, it's a bit like this. On the one hand, we've got people who feel normal experiences are being pathologized, and they're saying, no, let me out of this. Imagine the people on this side are the people who are against the expansion of mental disorder. The people on the other side are people who want their particular malady to be included. And those people include people who, in America, who will get insurance reimbursement if their particular affliction is recognized. But also people who are experiencing great suffering and believe that if their diagnosis is not included in this manual, that they're going to be neglected. But there are also people who feel that their experiences, some of which are positive, some of which are negative, are just roundly dismissed as disorder. And they feel that stigmatizing. And many people are subject to compulsory treatment, so inevitably will feel disempowered due to this concept. What happens if we decide that we don't really need that boundary or that door? What happens if we don't use it? Okay. So my response to this is to say the question of what is mental disorder is neither necessary to answer, because we can help people without it. It's not possible to answer because it involves a lot of value statements, and we can't observe values. We choose them, but we can't observe them. And it's not desirable to answer because the concept of mental disorder actually causes a number of the problems that trying to define it seeks to solve. We wouldn't care about stigma of mental disorder if we didn't have a threshold between order and disorder. There's a lot of confused faces. Instead of asking this question, I suggest we ask this question. What conditions, caused or mediated by the mind or brain, lead to a degree of suffering or impaired autonomy which merits the provision of care? That's a more useful question to ask than what is mental disorder. There's a good analogy here. I'm trying to look at my time, see if I've got time to discuss this. Does anybody here do gardening? I know Jill does, put you on the spot. Anybody else do gardening? Okay. Sometimes somebody's just started gardening. They're a novice gardener. And they ask you, is that a weed? Is that plant a weed? And the experienced gardener says, a weed is just a plant you don't want. Okay, so to ask the question, is that a weed? The person asking that expects a factual response, that there's somewhere out there written down a classification of plants as weeds and not weeds. But there isn't. There isn't. It merely is a plant that you don't want. So when we ask if something is a mental disorder, I argue that we're probably saying something like, is that an undesirable mental state to have? There's not a factual response to that. What are the clinical implications? Let's think about Natalie. Go back to Natalie. Do you remember Natalie? So let's bring this esoteric philosophical discussion back to what are the implications for real people? So a diagnostic approach would ask, does Natalie have a disorder? It's very common to hear people who adhere to a diagnostic approach saying, but is it mental illness? Like the novice gardener saying, is it a weed? What disorder does Natalie have? Long word rounds with differential diagnosis. How can we reduce Natalie's symptoms and stress and improve her functioning is the conversation that tends to happen. And interventions are given according to need and diagnosis, as is prognosis. A social approach, you say, has Natalie got an impairment? What societal barriers have caused Natalie to have this impairment? Is it our prejudice against people who hallucinate angels? How can we change these societal barriers? Can we be more accepting of Natalie? How can we support Natalie to overcome those barriers, if at all? A complaints-based approach would say, is Natalie distressed by this? No, fine. I don't think that's right, personally. But they would say, if she is distressed, why is she distressed? How can we reduce Natalie's distress and help her achieve her goals? And we would provide interventions according to a formulation focused on reducing her distress. A need for care approach would ask that question, but would ask another one. Is she experiencing a loss of autonomy through her experiences, as well as being distressed? Natalie arguably is not distressed, but it's an open question whether she's experiencing a loss of autonomy. And if those angels tell Natalie to do something dangerous, so on, is Natalie making a free choice? These are, I don't know the answer to these questions, but they're important questions, I think. How can we reduce Natalie's distress and help her regain her autonomy? And we would provide her with help focused on those two goals. So what actually happened to Natalie? So, although she caused no problem, she was taken to hospital and prescribed antipsychotic medication. In her mid-20s, she was detained on an involuntary basis and put on depot medication without consent, and she took her own life. And she left a note saying that she couldn't face living without her angels. Thanks very much.
Thank you, Paul. That was it was quite a challenge, and certainly challenged my understanding. I had certain assumptions around a social model. I think you've really challenged that and brought things into perspective, certainly for me. So we will open up for some questions. We've got colleagues, guests, and students online and here in the room. So we'll be going back and forth through to the two spaces. So first of all, I'll open up a question, which is, we know the things that you're involved in research and your impact and the impact of your research, but I don't know much more about Paul as a person. So what does it mean to you in terms of being a professor at Edinburgh Napier University? How has it changed you?
Well, it happened 3 years ago. That's the first thing to say. A couple of people said, "Oh, congrats on becoming a professor." And I said, "Well, it happened 3 years ago. Did you not notice?" Sorry. But no, yeah, I mean, I think it has changed quite significantly. In many respects, I think there's a wind beneath my wings around becoming professor. To some extent, when you become professor, that wind needs to be replaced by something else, I think. But no, it offers a lot of freedom, a lot of independence, a lot of autonomy. And it's a great community to be part of, a great professoriate to be part of. And yeah, I think it's, yeah. I sort of slightly worry I'm getting my professorial lecture 3 years after I became professor, because they hadn't quite made up their mind. But I think I'm okay.
Thank you, Paul. I had my children call me professor for quite a few days.
Don't you make them?
Okay, let's open up to our audience, both online and in the room. I know some of you know Paul really well, so you could help us, those of us who don't know Paul very well, you could help us to get us to understand him better, and the impact of his research as well. He is quite, doesn't like blowing his own trumpet, I've been told. So
did you hear the laughter in the audience when you said that?
So please, can you come forward with some questions? Please, can you tell us who you are as well, so we know if you're a guest or a colleague?
My name is David Black, and I'm not affiliated to any institution. I'm an investigative journalist.
Oh.
Ready? Right. Well, I could tell you a whole lot about Alan Francis and his tie-ups with Johnson & Johnson, but we'll leave that aside for now. It's pretty scandalous. What I'd like to look at is the current sort of war of attrition between not so much the social school as the biopsychosocial school and the biomedical school. And the biopsychosocial school has really set policy in this country, often called the Wesley School, of course, for about 30 years. In fact, you can go back to the Free Hospital 1950 epidemic of ME, and the way this was explained as, because it's all young nurses, it must be hysteria. So that's a sort of starting point, and then Engel and his theory, of course, became very prevalent. It's now being criticized quite heavily by people in the profession, by which I mean across psychiatry and all the other medicines, because it has a tendency to blame the patient, a sort of it's all in the head thing, which Suzanne O'Sullivan and others have been promoting.
This relates to chronic fatigue syndrome, ME.
Sorry?
This relates to chronic fatigue syndrome and ME.
Well, that's one of, I mean, other people say fibromyalgia and other things. It's perhaps not the only thing, but it's largely a post-viral condition. Nobody really argues with that in terms of the vast majority of people, or occasionally bacterium. But the way it's been sort of taken on by psychiatry, and it hasn't worked. And I think we have a coming storm in this country with the NHS and its funding, because it hasn't worked. Liz Kendall thinks she's going to get people back to work. She's not. These people are sick. So do you take a view on this division?
I'm aware of the controversy. It's not an area, the specific condition is not something I know a huge amount about. I'm aware it's an area that provokes incredibly strong feelings, understandably. And I think, if I could say, I think there's a lot of people who are critical of that school, who probably fall into the kind of camp of trying to get out of the kind of psychiatric diagnosis side, and they want recognition for this as a physical biological illness. I don't know enough about the area to have a strong view on that. What I would say is the reality, if you start trying to draw a boundary between what's physical and mental, it starts to get pretty tricky pretty quickly, because, and the social as well. And trying to tease apart, trying to say, well, that falls in that camp and that falls in that camp, it really gets pretty complicated because of all the interactions that take place between these different domains. And then trying to say what's causal sometimes is also very, very difficult. And sometimes I find that people have a favored, one way of conceiving of the arguments between the biological, the psychological, and the social is to sort of think about them as different levels of explanation. They're sort of all trying to describe the same thing, but just in a different level of explanation. So I understand it's a huge area, and I'm going to be wise and try to stay out of it and not say anything controversial about it, because that's okay.
While the microphone moves, I'll ask you a question that's come online.
Yeah.
The question is, are we reinventing the wheel in this area?
I in terms of, I would have to.
Let's.
It has echoes of the TC movement.
I have absolutely no idea what that question means. I do apologise.
Okay.
If I could ask for a follow-up.
Let's ask for a follow-up.
Hi, I'm Robin. Thanks very much for your talk. I really enjoyed it. Yeah, just going back to Angela, I think it's clear what some of the problems of you know, how she was treated. And I'm just wondering if you can explain a little bit more of what you think a better approach might have been, and how you would determine if someone has autonomy or they don't, and then what the approach is for kind of restoring that autonomy.
Well, that's great. I had a bunch of slides about that, but I took them out because it's far too long. So I suppose if I can, let's see if I can. Yeah, so essentially the blue is what I'm advocating for. And that's quite a simplistic kind of summation of what we would do. But to give you a sense of what we're trying to do, so we recently, you keep using that word, things that happened years ago, but we completed a trial of randomly allocating people, which involved randomly allocating people with psychosis to an intervention designed to support their decision-making about treatment, and an intervention which was more trying to understand in more detail why they've been judged to lack the capacity to make decisions about treatment. And some of the interventions we tested involved trying to, in relation to psychosis, there's a well-observed tendency that some people with psychosis tend to make decisions pretty quickly based on quite limited evidence. So one intervention was trying to support people to take their time in making decisions and to gather more evidence before doing so. Another one was around supporting people's self-esteem. So let's imagine for a second that Natalie had these experiences around a very valuable, very important experience to her. But let's imagine that it was starting to get becoming a bit of a worry, a bit of a concern. The angels were telling her not to do anything, for example, to stay in her house. Or they were telling her, they were commanding her, start to command her to do things like go to the top of a tall building and join them. You know, this can happen. So let's think if that happens. Then we start to care quite a lot about whether Natalie's autonomy is being affected by this experience. I would argue we need to have quite a high threshold for starting to worry about autonomy. But I would argue in that example, Natalie's not necessarily distressed, but she's posing a quite significant risk to herself. So what we might do in that scenario is try and see, is there another way for Natalie to get the benefits of these experiences that would allow her to start to question whether she should follow their commands, for example? Can we do anything to support Natalie to stand back a little bit from this and make a more informed decision about whether she ought to do that? That's not easy to do, but that's the approach I advocate. And we don't really know if it works, if I'm absolutely honest, because we have very little evidence around this.
Yep. We've got 2 more questions in the room, and any more questions online, Ron?
We've got a couple of comments rather than questions. Just somebody who's a trauma specialist agreeing with your standpoint, and somebody else commending you for the great work that you've done for people who do need hero years. The commitment you've given to this principled work, more yet to be done. That's Rory.
Oh, yeah. Say hi, Rory.
Okay, we have some questions at the back there.
Hi, I have a question. It's so is the next research, is it more about autonomy, or is it more just trials using this method and seeing what comes out of it? Like, what's the next steps?
There's sort of 2 things we're trying to do. One is the trial I mentioned to the person sitting in front of you was a pilot trial, so we need to go to the next stage of doing a definitive trial. So that's asking for quite a lot of money to do that, take quite a long time. And that's going to hopefully produce, for one group of people, some evidence-based interventions that can support them to make their own autonomous decisions about treatment, for example. The other thing that we're doing is with a number of colleagues, Amanda and Sean Harper and Catherine Newman-Taylor and others, we're trying to articulate how we can incorporate this concern for autonomy and this focus on suffering and autonomy into an inpatient environment. So we're starting to think about what would constitute an ideal kind of psychiatric ward, and how could we design that? How could we test that? How could we pilot that? What would that involve? And we're going to start trying to engage with all the various stakeholders around that. But this model forms a sort of theoretical, has an influence over our thinking around that. And I had another slide about that, but I took it out because it was too long. So those are the next steps, I think.
Hi, I'm Colin Mackay. I was kindly cited earlier on. I mean, I'm sort of attracted to the idea of the need for care approach, but I'm just trying to get my head around what its scope and boundaries are, because I mean, obviously the diagnostic approach is quite clinical. The social model of disability goes much beyond, you know, provision of medical care and things allied to medicine. It goes into employment, it goes into decision making, it goes into environmental barriers and so on. Just calling it the need for care just feels to me like you are kind of keeping this as a way of thinking about clinical interventions to support people and not about wider aspects of people's lives like their educational needs or other needs. I mean, is that fair?
I think that probably is fair, and I think it's quite important that people like me who are trained in psychological therapies and so on, and psychiatrists who are trained in a variety of things to do with the mind and brain, that's what we know. What we shouldn't do is say, is start to reduce all the problems that afflict people to the psychological, the biological, or the social. Actually, there's people who have an expert in social, people who have expertise in social policy shouldn't try to reduce all their problems to social factors, in my view. So I think there's a place for people like me, but it's not exclusive. There's a place for doctors, there's a place for nurses. There's also a place upstream from the people that we see in the clinic to modify what we know, and I have known for years, are the kind of social factors that ultimately cause this. And that's not unique to mental health or mental disorder. That's, if there's a clearest possible example would be smoking. You have, we need oncologists. We need the development of new interventions which can help people who've been diagnosed with lung cancer because they smoke. But the cause of smoking, most of the variance of smoking is accounted for by deprivation, inequality, and poverty. So we also need people to be tackling that. But I don't think wanting to help people who are suffering now or have impaired autonomy now precludes trying to operate at the social level. I'm just talking about things I know about.
We have time for one more, or? Yeah, we have time for two more. I'll include myself in that then. One here and then. So time for three more.
Hiya. Yeah. I was just wondering if you anticipate any challenges in implementing need for care as a paradigm in the current legal framework around duty of care and other kind of legal framework that affects the work that professionals do in the field.
Yeah, I think absolutely, and I think the much of the legal framework is focused on risk to self, which you can conceptualize as an extreme form of suffering or impaired autonomy, but it's also very focused on risk to others. And I think I said, hands up, I don't really know how to deal with that. I don't really know. I don't really have the answer to that. There's a part of me that recognizes that dealing with that is fundamentally important. Preventing harm to others is fundamentally, intrinsically valuable. There's a part of me that's very uncomfortable with a service designed to help people, also policing those people. And I accept that's the way things are, but I don't know how to think about that. So there's a real challenge there. The other big challenge to any new approach is that it can be quite difficult to think about a new approach while you're still implicitly wedded to the existing approach. So if you think about going to try on a jacket in a shop, if you've still got your old jacket on, the new one's not going to fit very well. And it's the same thing with concepts. If you're still wedded to a particular framework, a lot of the questions and problems that you have with a new approach are sort of born out of the fact that you haven't really fully suspended belief in the paradigm you're committed to.
Also, what was the trial? Is the trial study, the pilot study, sorry, already published?
Oh, well, it's after being rejected by multiple journals, it's currently decision in process, and it has been for a week. And I was joking to Jill that during this lecture, I'll probably get an email saying rejected again, and my suffering will increase.
I should add that he's published numerous papers in very esteemed journals.
So it will be soon. It will be soon. I have faith.
Thank you for that. I thoroughly enjoyed the talk. That was good. I was at Napier Merchiston in the days when we had open lifts and jumped on and off. Health and safety has moved on somewhat since then. But as a person who was doing engineering at the time, one of the things that I find with this whole subject is diagnosis. If I, as an engineer, went up to something and tried to measure it, and somebody else came up with a different ruler or a different method of measurement and all the rest of it, we wouldn't build anything.
Yeah.
And I can remember being at a talk and they were talking about diagnosis. And I said, get a big disc, punch holes in it where you think you are on that disc. And a lady who was sitting next to me said, that's been done by a German in the 40s, I think it was, or 30s. You know, so it's nothing new. But to me, it seemed really odd that you had to fit these people in these boxes because that's where they had to go. Whereas as an engineer, you know, you don't go, that building's the wrong size, knock it down because I want it to be in that box.
Yeah.
And that's what I was going to ask you. And again, thank you for that.
Well, I'm not sure I've got the question entirely there. Is there?
The question was, diagnosis seems very important, but it also seems arbitrary. You get one person who will tell you this is what it is.
Right, okay.
And someone who will come and go, this is what it is, and they're both trained maybe in the same field.
I mean, that has been a critique of diagnosis, and that has really informed the development of diagnostic manuals. But if I could defend it, it is actually highly reliable now. The ability to identify people, there's a lot of reliability. Validity is another is a question that's rightly we should ask. One of the difficulties with using an engineering analogy, and this is sometimes where analogies can get us into difficulty, is we start to use an engineering analogy, or we start comparing people to plants, like I was earlier. The thing is, they don't respond. The doors and windows and lifts don't tend to change once we classify them or measure them. They don't say, "Oh, really? Am I?" and start to. We don't tend to have that looping effect that we see. And I'm not saying a looping effect is an intractable problem that prevents us being able to help people. But I will say it's very real. And my colleagues, your GP colleague in Edinburgh, is very acutely aware of, for example, some of the things that are happening right now in relation to people seeking treatment for particular conditions, and a huge increase as they've been publicised and talked about. And I won't go into that, but we see people start to relabel things they previously accepted about themselves or didn't like about themselves as symptoms of an illness. That can be helpful. In fact, it could be so helpful. Yeah, it could be helpful. It could be helpful. And it's so helpful, it actually forms a crucial component of an evidence-based intervention, is actually adopting the illness model, the illness role. But it's also tricks us a little bit as well, and it stops us. It can, I think, lead us into some conceptual tangles as well. But ultimately, it can help people, and I'm not against it, as a paradigm.
Okay, thank you. So final question from me then, Paul. I'm sure you are inspiring the next generation of researchers in this field. I'm sure there are some of them in the audience as well, and some in your classes that you teach. So who has inspired you to get into this field?
Oh, that's a good question. I've met quite a few of my heroes now, and I'm pleased to say that they didn't disappoint. You know, I mentioned some of them in the talk. A particular inspiration has been Bill Fulford, I think, who I had the pleasure of meeting. Another one is Richard Bentel, and Bill Fulford and Richard Bentel had an exchange in a philosophical journal because Richard Bentel wrote this pretty satirical, provocative article called "A Proposal to Classify Happiness as a Psychiatric Disorder." And he was basically just tongue firmly in cheek, trying to use basically saying, look, states of happiness can meet all the criteria for mental disorder. It was a reductio ad absurdum, and Bill Fulford engaged with that. And he made a fantastic observation is that, well, that might be right, Richard. That's actually, you're absolutely right. We've really struggled to define this concept. But we also try defining time. Try defining time. We all use our watches, though. Come up with a definition of time that meets necessary and sufficient criteria. So we operate with concepts that we can't fully define in a philosophically tight, defensible way all the time. So anyway, sorry, that was just a little story about those two, who I admire greatly. And I wish Bill Fulford's work was more recognised, and I hope it will be. Yeah.
Okay, thank you. We know a little bit more about you as a person now, and clearly a lot about your research. So thank you for such an interesting and engaging lecture, and I certainly look forward to hearing more about the impact of your work. So let's thank Paul for his work and his contribution.